Okay, good evening. Welcome, everyone. Going to continue to admit people. Again, my name is Aisha Akhtar, and I'm the Director of Education with the Epilepsy Foundation of Greater Chicago. And tonight we have a very special presenter for our virtual chat series. He is also the chair of our Medical Advisory Council. This is Dr. John Millichap. And so I'm really excited to have him here, and he wants to do something kind of different. So we're going to see how this works. Super exciting. He is also on staff at Northwestern University as an associate professor. And so he is going to be having a talk on pediatric epilepsy. And if there are any of you who have questions related to maybe your adult epilepsy or what have you, there is still a space for you here. So please feel free to ask any question at any time in the chat box or maybe at the end if we have time. But for now, I am going to present some questions to Dr. Millichap that have come to us through our registration. So some of the categories that we got were diagnosis, medication and treatment, and triggers. So what we'll do is we'll go ahead and start with sort of some of the high level topics when it comes to diagnosis. And then also, Dr. Millichap, when you start, I would love for you to just kind of reset the definitions for a neurologist versus an epileptologist. I find that is commonly misunderstood. And then if you could just start by talking about sort of like the basic process of diagnosis and maybe some of the etiology behind seizure types. So maybe we can start right there.
Sure. Well, good evening, everyone. This is another edition of our chat series, and as was already said, usually we have a lecture with some slides and a specific topic ahead of time. And we were brainstorming and thought this might be helpful for folks to be able to send in questions and get them answered more specifically, sort of as a community chat. So we'll be interested in your feedback about how this goes and how helpful this is. So I was asked to give an overview of the difference between a neurologist and an epileptologist. So an epileptologist is a neurologist. So as physicians, we do general training as far as medical school, and then training in general health conditions. Then we do training in neurology specifically for several years, where we will learn about adult and pediatric specific neurological problems. And then we have the opportunity to start practicing medicine at that point and not have a specific focus. So we would see patients with epilepsy, we would see patients with muscle diseases, with headaches, with other problems that are attributable to the nervous system. And there's also opportunities to specialize. So some doctors will specialize in muscle diseases or will specialize in epilepsy. And that's extra training where you would learn how to read EEGs, for example, and also become familiar with the specifics and intricacies of epilepsy surgery, which is obviously a very important treatment and needs extra training in order to understand who might need this and the tests that are involved in determining how to do this. So the bottom line, a neurologist can treat seizures and epilepsy, but if the situation is complex or if the diagnosis is maybe uncertain, an epileptologist can be seen once or can be seen many times and follow the patient to treat that condition specifically. So in pediatrics, actually the majority of pediatric neurology is epilepsy, and there are fewer other conditions that occur in children. So a pediatric neurologist may be more familiar with seizures than, say, an adult general neurologist.
Good to know. So, what are the steps for getting that diagnosis? You mentioned EEG. Could you elaborate just a bit on what that is like?
Sure. So when a neurologist or an epileptologist meets a family or a patient, we will often be told about a spell, something that happened that was concerning for a seizure. And so the first thing that's going through my mind is this a seizure or is it something else, which is possible? And ask several questions, listen very carefully to the description. I'll often ask the family to tell me what happened without using the word seizure. I think that's a helpful question, because some people will come in and say had a seizure, or use some of the common terms that they might have heard used in the other hospitals or with other doctors, like GTC, generalized tonic-clonic seizure, but often that term is overused, and there's more specifics to how a seizure might start. Like the head turns to one side, which can be important, or the eyes go to one side, or some other behavior, which can give us a clue where the seizure might be coming from. So I ask these questions, and if I determine it's a seizure, then I will try and determine what type of a seizure. There's many different types of seizures, and the International League Against Epilepsy has groups of doctors who get together, it seems about every 10 years, and change the names of the seizures, just to keep us all on our toes, but seriously, so that we can be more specific in our diagnosis and communication, and just an updated understanding of what seizures are and where they start and where they go. So thankfully, this last update a few years ago has gotten away from terms that require a dictionary or definition, such as complex partial seizures or simple partial seizures, you might have heard. Those terms are now been replaced with more English words or descriptive terms. You might say focal epilepsy with or without loss of awareness. Everybody without medical training understands what that is, more or less. So those are the two big types of seizures. There's either focal seizures or generalized seizures. So a focal seizure is one that begins in one area of the brain and then may stay in that area, or may spread across the entire brain. And a generalized seizure is considered one that starts on both sides of the brain at once. And of course, it must start somewhere. We just think it starts very deep down in the brain, and we'll be able to see that on top. But on the outside, the behavior will be different. With a focal seizure, just in one area of the brain, the person may just be confused, not responding normally, usually with their eyes open. The eyes may go to one side. There might be twitching or jerking on one side of the body, or a person might have strange behaviors, walking in circles, or twiddling their fingers, or readjusting their clothing in a strange way. So these are very subtle signs of seizures that we've learned about from observing many seizures on video EEG or in other situations, or listening to stories from observers. And sometimes that seizure can start that way and then spread and go across the brain and involve more of the brain. So then you see the convulsion or the jerking of both sides. So it's very important that I ask for the details of how that seizure began, because that might help me differentiate between a focal seizure or a generalized onset seizure. And the reason that's important is, we'll get to in the other topics, is the cause, or the etiology is the other term of the epilepsy. So generalized seizures and focal seizures have different causes. So there's many different causes of focal seizures. You can be born with a change in the structure of the brain. That's something that happens when we're inside the womb and our brain is first developing, usually in the first several months of development in the womb. And a simple way to think about it is the brain is sort of layers from the inside out. And the brain cells of different types fill different layers of the brain, and they just don't get to where they're supposed to be. And so we call this a malformation of the brain. And you might think, oh, that this would be easy to see, but actually looking at the structure of the brain from the outside, if we were able to see it, we may not be able to detect this malformation. It can be on a microscopic level. And this is where seeing an epileptologist versus a neurologist, or going to a specialty center like we have many in Chicago, might be beneficial for diagnosing a subtle malformation of the brain. At an epilepsy center, we have different types of epilepsy centers. There's the NAEC is a national organization that will accredit the epilepsy centers. And so a higher level epilepsy center will have more expertise and other tests that are available to help determine the cause of the epilepsy. So there might be a higher resolution MRI, for example, that would be used at a community hospital. They might have one that is very good, but one at an epilepsy center might be done in a way that is, as I said, higher resolution. So you might think of a CT scan, sort of like black and white television, and an MRI with a 1.5 Tesla. Tesla means not the car, but the magnet designation or strength of the magnet in the machine. A 1.5 might be like the flat screen TVs we had 10 years ago, and now the 3 Tesla or higher is like the ultra high resolution 4K TVs that are now available. So what you couldn't see on the 1.5 or on the CT scan, you can see better on the 3T MRI.
So on the EEG, you're looking for spikes, and that's going to define the seizure activity, correct?
Right. So
okay.
So listening to the story and then doing a few basic tests. Thanks for getting me back on target. So the basic tests that we usually do is listen to the description, our examination, listen for any family history or any risk factors for epilepsy. There was an accident, there was trauma. If it was an adult, they were in the military and suffered concussions. Or a child had birth issues or some other injury or an infection of the brain. These multiple risk factors can help us determine the cause of epilepsy. And then we will do an MRI and an EEG. I spent some time already talking about MRI, and the EEG stands for electroencephalogram. And this technology has been around for 100 years and is used for picking up very small electrical activity that's given off by the brain cells. So we generally consider that the amount of brain surface needed to see a spike of electrical activity on the surface of the brain is about that big. So it's not a pinpoint or very specific type of tests. So that's why we talk about the front of the brain, or the back of the brain, or the side of the brain, because that's about the resolution that we have as far as the location of the spikes. And we will see normal activity when a person is awake or asleep. And this changes a lot. I would say that myself, a pediatric epileptologist, I find it much more interesting because there is such variability from birth through 12 years old in the EEG, as the brain matures over this period of time, the normal patterns of the EEG changes dramatically. After about 12, until we get much older and into geriatric time, we start to slow down again. But the EEG waves are at a certain frequency, or ups and downs per second, in different areas of the brain, and they are slow when we're babies, and then they gradually get faster and faster as we're in childhood and adulthood.
Yeah.
And we have to be able to distinguish what's normal and what's not normal for age. And if there's an irritation or a focus where the seizures are coming from, that's where we might see a spike. And so a spike is what it sounds like. If you imagine the waves of the Lake Michigan, the big swells, that is the type of brain activity that we might see when a person is awake or asleep. But when there's a spike, it looks like something it might hurt to sit on.
Mm-hmm.
And that's because a lot of brain cells have all fired off together in an abnormal way. And a seizure on EEG looks like a bunch of those little spikes. So like that area of the brain just keeps firing off.
Right. Now, you and I have talked a lot about concussions and how that can possibly, like, one of the pathways from a concussion can possibly lead to epilepsy. And can you just maybe expand on that just briefly, that can be something that could happen, or maybe it can happen, but that they're loosely connected?
Right. So, the terminology, I think, is the most important thing. I think there's a lot of controversy about the terminology and linking concussion with seizures or epilepsy. And then I'll just say the definition of epilepsy versus seizure is 2 or more unprovoked seizures. So some people, you may have one seizure in your life or have some stress that is unusual that causes a seizure at that time, and that may not be considered epilepsy per se, as determined by your physician. But the link between concussion and epilepsy, as I was starting to say, is not necessarily linked. But if you look at the terms that are used for traumatic brain injury, and this has gotten a lot of press with the NFL and boxing, when we learn about and the wars that we've had in the recent past, and our veterans coming home with traumatic brain injury and suffering from epilepsy. So there's mild, moderate, and severe TBI or traumatic brain injury. So some experts will consider concussion of certain types to be a mild TBI, and there are studies that link mild TBI to epilepsy. So I think that's a loaded question, that whether concussion itself is related to epilepsy. And there's all these caveats that have to be considered.
Great. Yeah, thank you for making that clarification. I want to now move, I know there's a couple more questions within the diagnosis section, but I'd like to move a little bit to medication, and we can always come back just to make sure we get everything kind of touched upon. So now a person has been diagnosed, you've given the proper diagnosis, and you've created a treatment plan. And obviously, ideally, we would like early diagnosis as best as possible. And we know that medication works for 70% of people who are who have a diagnosis of epilepsy. So what is that process like for you? How does it start? How do you know how much medication? When do you pull back? What's the titration? Walk us through all of that, please.
Sure. So, once you've thoughtfully listened to the type of seizure and done your best to have an idea of the cause or the etiology, that will help you select the best medication. There's some medications which are specifically used to treat specific types of seizures. And sometimes of these 20 plus medications we have available, some are better for certain etiologies as well. But in the large majority of epilepsy and seizures, we would first select what we call a broad spectrum seizure medication. And that is one that would treat both focal seizures and generalized seizures. This can be useful when the person is not necessarily, or the physician is not 100% sure what type of a seizure it is, because usually these broad spectrum medications will not make things worse. There are some situations where some medications that you might use for focal seizures specifically can make generalized seizures worse. So we need to be cognizant of that and make sure that we make the right decision early on. Unfortunately, we have not quite got to the point where we're very personalized or precise about our treatments, and we will take the best medication from one of these two buckets and hope that it works for that patient. We will also consider things like side effect profile. So if a person has difficulties with gaining weight, for example, we're going to stay away from a seizure medication that is known to be an appetite suppressant, because that might make that condition worse, or vice versa. There's some medications that increase appetite or can increase weight gain, or some other more specific issues. If you have liver or kidney problems, we're going to try and stay away from seizure medications that are associated with an increased risk of stress on those specific organs. We do try to select the medications specific to the seizure type, as specific as possible to the etiology, and taking into consideration the patient's other health conditions or their characteristics of their personality.
Right. And it's so important for your patients to communicate with you any side effects or any changes in mood or activity levels or energy levels. I think that's a very important conversation to be in constant communication.
Yeah, and it is a difficult thing to discuss, but it is something that we do have to talk to all of our patients about, that every single seizure medication has an FDA warning about the increased risk of suicidal ideations or suicide attempts. So these are things that they've done statistics and found that people with epilepsy may have these issues, and every single medication, not one or the other, but every single one. So that's why exactly we ask parents and patients to tell us right away if we start them on a new seizure medication, or even if they've been on one, they have any sort of changes in mood or feelings of this sort, that they need to bring them to our attention.
So how do you know when it's right to adjust the medication? Like, when would you increase it? Maybe for kids who are hovering around puberty, or how would you determine if someone's dosage is still high and they're still having a lot of seizures? How do you make those determinations?
Well, specifically for children, the dosing is usually age and weight based. So depending if the medication is metabolized or cleaned out of the body by the liver, for example, the way that a child's liver metabolizes medications is much different than an adult's. We're actually slower at metabolizing medicine than kids. So they will need a higher dose per weight usually than an adult would, which is surprising. But it's something that we have to take into consideration so that we have the right level of the drug circulating in the blood and transferring over into the fluid in the brain. So we will use usually a weight-based determination to make that first dosage recommendation. Different medications are started and increased in different ways. Some start out at the dose that they're going to work. Some need 3 months to get up to that dose. So each medicine has its own specific characteristics and how it interacts with most people's bodies. And so I just want to explain that we are, everybody's an individual. Each patient is an individual, and each person reacts to medications differently and in a specific way. And so we make our best approximation of what dose of medication will work for that individual. But we may need to adjust it up or adjust it down depending. Did the seizures stop? Are they having side effects? Usually, if seizures are continuing, we will continue to increase the dose of the medication up to a point where they may start to experience side effects, like you might be tired or you might experience some dizziness, and then back down a little bit. Then you know that you have maximized that medication for that individual patient. And if the seizures are still continuing, despite maximizing that appropriate medication, then it might be time to change to a different one.
Okay, thank you. Are we able to transition to triggers? Would you like to say anything else about medication, or can we move on to triggers for a bit?
No, I think just to emphasize that we have many medications now. The older ones are still very good. So there's a few that have been around for 40 years or more, and the more recent drugs have better side effect profiles typically, or can be taken once a day, or have other attributes to them. Unfortunately, overall, we have still not been able to decrease that number. There are 30% of patients with epilepsy that we can't control with medications. And so if medications are not 100% effective, this is a good time to seek that consultation with an epileptologist to consider other non-medication treatments that include but are not limited to dietary therapy, so ketogenic diet and variations of the ketogenic diet, the vagal nerve stimulator, which is a device which can help reduce seizures, or some form of brain surgery even, which sounds scary, of course, but the epileptologist would have a discussion with that family or that patient if this was a possible beneficial treatment.
And I'm just typing in the chat. I was chuckling at the transcript for vagus nerve stimulator came up as Bangladesh. So I thought I would make sure to type that properly so that people could understand what you said. So let's move on to some triggers. So now we have we're at this moment where a person's been diagnosed, they have a treatment protocol, and they might even have rescue medication. Not everyone has rescue medication. So maybe if parents are wondering, well, how am I going to know when my child is going to have a seizure? What would trigger it? What would not trigger it? Some people wrote in and said that when their child used the bathroom, they could have a seizure, or could there be any impact by climate, or also children getting seizures around the time that they are sick. So could you talk a little bit about these kinds of triggers?
Sure. So as I've said before, with medications, everybody's an individual. So I've heard over the course of my career, many different types of triggers. The basic understanding of triggers is when there's a situation that lowers or could lower the seizure threshold. So everybody who doesn't have epilepsy has a certain threshold where if they are stressed to that point, they may have a seizure as well. So a person without epilepsy who gets very hot and will eventually probably have a seizure. There's experiments with laboratory rats, for example, who don't have epilepsy per se, but if they're heated up to a certain temperature, then they will have a seizure. So you can imagine a person with epilepsy, which means a lower threshold, when they have stresses of everyday life, that is when they might have a seizure. So these common stresses are not sleeping enough at night, being upset by something, being excited by something even, or certainly illness, whether it's with fever or not. So these are some of the common ones. So, having seizures when you see flashing lights is not a common thing, but it can happen with some types of epilepsy, more often the generalized seizures. Using the bathroom can change the, depending on the type of number one or number two. It can be some extra stress on that person, and that might just be enough to tip them over. But of course does not happen to everyone. So when I hear about these specific types of triggers, I've heard people eat different foods and that triggers them to have a seizure. It happens on their birthday because they're so excited, we gathered. I say either be prepared if it's some situation that can't be avoided. You can't avoid your birthday or going to the bathroom, but be prepared. If this does happen, make sure that you're sitting down or have a seat that has some support around it, or if it's a child or possible, have a caregiver there, when the bathroom is being used, for example. Just be proactive and conscious about these things. Sometimes, I think it was in one of the written questions, my child has seizures when they're sick or about to be sick. Sometimes we will hear about the seizures being the first sign of illness before the fever comes. And this is because the body is mounting an immune response, or if there's inflammation in the body, that is that stress even before the fever occurs. And this has been linked to vaccines as well. If you have a lower threshold for seizures, you can have a seizure when the body is having the normal response to the vaccine. That doesn't mean I say don't get vaccines. It means be prepared for potential breakthrough seizures when the vaccines, because obviously the illness that the vaccine is protecting the person from would have a much higher immune response that could be even more dangerous.
Thank you. Someone also asked about climate. So I think that's similar to what you were saying, is just kind of just being prepared, but if you wanted to mention anything.
Yes, I think the question was specific about have there been any studies that
Right.
look at this. I'm not aware of any definitive studies that linked changes in barometric pressure. Obviously, these things do affect our bodies. People will have pains in their knee joints when the weather is changing. If they have a sensitivity there, people can, it's a real thing that you can be sensitive to the changes in the pressure when the rain is coming or not, so high and low pressure systems. But there's no specific link to that, or flying in airplanes where the pressure might be higher, or being in high altitude. But you can imagine if you usually live in Chicago, but you go to Utah to go skiing or in the mountains for some other reason, everybody feels not
For
normal.
sure.
Initially, you have to acclimate. So a person with epilepsy should be extra careful because that could produce stress and therefore trigger.
Right. Actually, on that note of breathing, we had a question about what triggers cyanotic episodes. So if you could expand.
Right. So cyanotic episodes means, if I'm understanding the term correctly, cyanosis means that there isn't enough oxygen in the blood, and that you might see that we would say sometimes blue around the lips. So if a person is cyanotic, then in these mucous membranes, like the lips, we might see that it's blue, or the fingertips. And that can be, it's a very non-specific finding in my, or symptom in my experience. This can be caused by problems with the heart. If the heart slows down and is not pumping, or even if it's pumping beating too fast and not pumping properly, not getting enough blood around the body, not getting enough blood to the lungs, you might not get enough oxygen, and that could be producing cyanosis. Somebody who passes out as syncope might display cyanosis. But I do also see this sometimes in people who have prolonged seizures. They might have cyanosis. And the specific triggers for this type of seizure would be the same as for any other type of seizure typically, unless the question is about a specific type of epilepsy that there is no syndrome that I'm aware of that is called cyanotic epilepsy. But this can certainly be a symptom of seizures, but also, as I said, of heart disease or other problems with the circulation. Right.
And I once was working with a school district way up on the north side, I think Waukegan, where they had a student who presented seizures this way. And it was very jarring for the entire school system to see this, that this child was turning blue. But in fact, it was actually listed on the seizure action plan that his mouth turned blue. But it got to the point where like the fire department got involved, EMS got involved, because no one was able to really understand. Like there just wasn't a lot of information. So I think back to one of your original points, which is that to provide your physician with as much information as possible and making sure that you are presenting an entire story so that everyone is aware of what's going on, what all the symptoms are. I think it's a very important point.
Yeah. Yeah. So when if that's the only symptom, that would be unusual, but probably not unheard of. And the diagnosis of such a seizure would probably need a EEG to be done with a video camera at the same time as the event to document that there is a change in the EEG when that symptom is occurring, and that the heartbeat is normal, etc.
So kind of staying on that EEG topic, one of the very first things you talked about was, which I was laughing, the ILAE, always changing the terminology. I really think it's job security, at least for someone like me, to be able to come in and talk about the new names. But in 2017, they also created this sort of unknown category, right? There's generalized and there's focal, and then there's unknown, where it's not sure exactly the etiology or where the seizure is coming from. How often do you see that, or do you mostly see generalized or focal?
The rare seizure types are rare, but we might see any of the different seizure types that are described. And I think that the terminology and descriptions are very important, and can point us towards the specific etiologies, or more importantly, towards the specific treatments that might be more beneficial for that individual.
Okay, thank you. So I'm going to ask if anyone has a question. You can type it in the chat. And while you're doing that, Dr. Millichap, there's one more topic that wasn't listed, but I think it's really important to mention, and that is the topic of SUDEP. I think it's really important that we as providers, well, you as a provider, not me, but as educators, that we talk about it. If you could just talk a little bit about some of the risks involved and some of the things that go along with SUDEP, I think that would be very important.
Yes, and for the family members, caregivers, and patients that might be listening to this, this is something that your doctor really should discuss with you, and you should ask about. But it is an uncomfortable subject, and they may have not asked about it directly, but or spoken about it directly, but maybe more indirectly. And it's important to have this conversation. So SUDEP stands for sudden unexpected death in epilepsy patients. And as epileptologists, we've been talking about it for over a decade. This is still an area of research, and we have learned a lot, but we still have a lot of questions about what is SUDEP, and what are the specific causes, and how can we avoid it or prevent it. You might consider it, if you've had children, something similar to the conversation you have with your parent pediatricians about SIDS, the infant death syndrome, and the pediatrician says, always put your child, back to sleep, and of course you see them 2 minutes later and they've flipped over on their front, or don't you put a pillow in the crib. And so these are all things to reduce the risk of SIDS. And so the SUDEP is sort of the same thing. It's something that we need to discuss so we can understand that individual's risks, and try to reduce those risks of SUDEP. And it's quite common sense that persons with worse epilepsy or worse controlled epilepsy have a higher risk of SUDEP, but everybody is at risk. So the highest risk factors are convulsions, uncontrolled convulsions, ones that happen at night, failing multiple medications, and failed epilepsy surgery. These are some of the higher risk factors. So that individual should be on higher alert and trying to watch and beware of the risk of SUDEP. But even children who have very few seizures, per month or per year, or in their lifetime, are at risk of having SUDEP as well. And there's been some high profile situations where there is SUDEP, but it's a much higher chance of having injury or death related to epilepsy from injury, drowning, some sort of an accident during a seizure, than to have SUDEP. So thankfully, it is still relatively rare compared to other things.
Right.
Unfortunately,
Right.
there's risks all around us.
Sure.
Car accidents, etc., which
Right.
are higher risk
Right.
at this time.
Right. I have two written questions, and then I have someone, Claire, who has a hand up. Claire, would you like to ask your question, or do you want to type it?
Sure, I can ask it. Thank you so much for doing this, Doctor. We really appreciate it. I have a 4-year-old that was, previously very healthy and just kind of developed this very explosive, just difficult to control, as you would describe, focal with seizures where she's not aware, which is now drug-resistant epilepsy. She's failed many meds and has had exhaustive testing. We've taken her all over the country to different centers, and nobody can quite figure out what the etiology of her epilepsy is. So my question to you is, what advice do you have to parents with children with poorly controlled epilepsy without a known cause? And what are the next steps, or what? I mean, we're starting a ketogenic diet, but just kind of like big picture, what can those parents do for their children?
Right. Well, I'm sorry to hear that the seizures haven't been controlled, but I'm glad that you've sounds like you've sought out second opinions, and it sounds like an opinion with an epileptologist. I didn't even get into genetic testing or other forms of testing for etiology before, but I think for everybody to understand that the doctors are choosing medications based on the seizure type and the known etiology, but sometimes we never quite figure out what the cause is, and sometimes it will necessitate repeat testing. So sometimes you'll do an MRI, for example, and it won't show this very subtle malformation, and then you repeat one, and it will. Or you do one type of genetic testing and it doesn't show the specific cause, and then either repeat the testing later in life or do a different type of testing, and it does reveal the underlying cause. But there are a high proportion of patients I've cared for and who don't have an underlying cause necessarily determined. So at that point, the epileptologist is going to be treating the seizure types, and will recommend different treatments such as the ketogenic diet, vagal nerve stimulator, which is etiologic, non-specific, and consideration of potential epilepsy surgery, where more tests would be done, which might actually reveal a previously undetermined etiology. So I think the advice is to keep trying, and the myself included and other epileptologists need to be mindful of not using too many medications at the same time. We can sometimes get stuck with adding medications and not taking them away, which will just muddy the water, so to speak, and not make it as clear which one is working, and also would increase the risk of potential side effects for that individual patient. So I think working with your epileptologist, keeping them apprised of how the medications are affecting the seizures, and not to give up and to keep trying new things. I would say I've had situations where children were having uncontrolled seizures for many years in my care, and we keep trying new things, and eventually we find the right combination, whether it's the treatment or how their brain is developed and they're beginning to outgrow it, or they're in a different phase of life or of their epilepsy where we're able to get control.
Could you also clarify whether myoclonic nighttime jerkings is a type of generalized seizure?
Yeah, I saw that question. What about nighttime myoclonics? So for everybody, a myoclonic jerk is a very quick body jerk, so like a split second. And typically it's, if it's a seizure, it's typically a generalized seizure, but you can have focal onset myoclonic seizures as well. It is possible, but less common. Similarly with tonic seizures, which is stiffening of the arms, typically, that is typically a generalized seizure, but you can have focal tonic seizures as well, which is more rare. So after a child typically is diagnosed with epilepsy, within the first couple of weeks, we'll get a phone call from the family saying that they are seeing their child jerking in sleep. And that's because they've begun staring at their child sleeping. And many of us will have jerks as we're falling off to sleep. This is called benign sleep myoclonus. I know I do it. So quick little jerks. And if you haven't watched somebody or your loved one fall asleep before, you may not have noticed them, but they can be quite dramatic sometimes. So it's good to differentiate those from seizure jerks. Typically, seizures occur with the eyes open. So a seizure myoclonic, a myoclonic seizure from sleep might wake the person up in most cases, whereas a benign sleep myoclonus, they would stay asleep. But that's not 100%. I think if it's really concerning, we have to have an EEG on while the person is sleeping and actually record that with a video and the EEG at the same time.
Okay. And how often do you want someone to do, whether an MRI or an EEG?
Well, I think it depends on the severity of the epilepsy, and if we know that the person has an abnormal MRI, then it's probably unless it's a tumor or we're afraid that it might be growing or changing, that would usually be the frequency of the MRIs would usually be dictated by a surgeon at that point, who would be monitoring that. But for epilepsy, we want to repeat the testing in a interval where we would do something about it. So if a person's had an MRI and their seizures are well controlled, then we may repeat the MRI at 2 years, seizure-free without medication changes, because we want to make sure that we haven't missed anything. Repeat the EEG as well, see whether it's normal at that point, because at that 2-year mark without seizures, we might actually, in a child especially, have a conversation about trying off medication. So that would be a time to repeat these tests. So the answer is it depends. More frequently, as I said, if there's continued seizures and new seizure types, for example, we might do an EEG or some other change in the condition, weakness on one side or some other issue, we might repeat both the EEG and the MRI.
Thank you. Can you also please reiterate, I know the very first thing I asked you to do was to explain the difference between the epileptologist and neurologist. Could you just please reiterate when you want someone to see an epileptologist, like when should they make that determination?
Sure. So the discussion amongst epidemiologists, these are people who look at statistics of epilepsy, and the great wish would be that every patient who has epilepsy would see an epileptologist at least once. But there just aren't enough epileptologists in the world, or people don't have the access or resources to get to an epileptologist or to see more than one doctor for their condition. So that would be the ideal. But really asking for an expert consultation, it can be one time, and the epileptologist's recommendations can then be reviewed by the patient's neurologist and used accordingly. If that individual is not responding to the initial treatment, or if there's uncertainty about the etiology, it might be useful to see an epileptologist or to go to a level 4 NAE center.
Thank you. We are kind of running up on time, and I feel like we've talked about a lot of different things tonight. Is there anything that we didn't mention that you absolutely want to make sure you convey tonight?
I think that this was a useful forum to answer some specific questions that came up from those who registered. But my responses were, as needed to be, quite in general and broad. So I'll be interested to hear feedback, whether the format like this would be useful to do on a regular basis, or continue with the more traditional lecture type webinars.
Yeah, I thought it was great. I think giving people the opportunity to ask a question, and of course we can't answer specific questions, but to create little groupings. It's also nice to see kind of where the majority of questions lie. And today I think there was a big chunk of questions and triggers.
Yes. So if we continue this, it'd be interesting to hear how new questions come up, or over the years how focus changes. Yeah.
Yes, thank you. Well, definitely lots of high marks for you tonight in the chat. So thank you so much for being here. You have a lot going on.
My pleasure.
And again, this will be recorded. Oh, this is recorded, and this will go on our YouTube page. And so you're always welcome to come back and take a peek. Thank you, everyone. And then meet us again next month for our next virtual chat. Thank you. Good night.
Thank you.
Thank you.
Thank you so much.